I want to take this opportunity to thank the organizers and the Elizabeth Dole Foundation for giving me the opportunity to make this presentation at the Fifth Annual National Virtual Convening of Caregivers at the Forefront. Throughout my entire life, I've had an abiding respect and admiration for veterans and military, and it gives me a great pleasure to participate in this particular conference. As you can see from this first slide, I've chosen as my title the public health and scientific challenges associated with the historic COVID-19 pandemic that we are currently experiencing. This slide is a cover of the Journal of the American Medical Association, in which my colleagues and I, in January of this year, wrote a viewpoint. You could see that the title of the paper is Coronavirus Infections More Than Just the Common Cold. By no means did I mean to be facetious with a title like that, but I just wanted to point out to the readers that we had been involved in dealing with coronaviruses for decades and decades. And let me explain what I mean. This is called a phylogenetic tree, which lists all the viruses that are connected molecularly. There are a number of human coronaviruses that are shown in red letters, but coronaviruses also infect bats, and bats and other intermediate hosts may be the major reservoirs of this. Now, as you can see in the 4 coronaviruses that are shaded in yellow, those are the 4 coronaviruses which, for an indefinite period of time, as far as we can gather, have been responsible for about 15 to 30% of all the common colds that you and I experience repetitively virtually every winter. They are relatively benign with few exceptions. Then what happened is that in 2002, we experienced the first pandemic coronavirus, SARS, or the severe acute respiratory syndrome, which emerged from Guangdong province in China, led to 8,000 infections and almost 800 deaths. A true pandemic, but given the fact that it did not efficiently spread, it was able to be contained by public health measures. And then 10 years later, in 2012, we had the second coronavirus pandemic, or MERS, Middle East Respiratory Syndrome, that originated in Saudi Arabia, from a bat to a camel to a human. So we have now 2 diseases, the severe acute respiratory syndrome, again from an animal host, a bat, to a civet cat to a human, lasted about a year and a half, contained by public health measures. Then MERS, we still have some smoldering reintroductions of this virus into the population, predominantly in the Middle East. But now we get to the present time, the 3rd pandemic coronavirus, first recognized at the end of December in 2019, and then identified with its molecular makeup as a coronavirus in the first week of January of 2020, and put on this phylogenetic tree. You see it's very proximal to the original SARS virus, which then led to a renaming where the original 2002 SARS virus was called SARS coronavirus 1, and the virus we're dealing with now, with this unprecedented pandemic, is called SARS coronavirus 2. So getting back to the terminology, the disease itself is called COVID-19 for coronavirus disease 2019. And as I mentioned a moment ago, the particular virus is SARS coronavirus 2. So where are we now with this historic pandemic? It has exploded upon our world as the most extraordinary and impactful pandemic in the last 102 years, ever since the famous 1918 swine flu. So as of just a day or so ago, there were 38 plus million cases worldwide and over 1 million deaths. Unfortunately for us here in the United States, we have been the hardest hit country in the world, with about 215,000 deaths and close to 8 million infections throughout the country, with this heat map here showing with the darker colors the most involved sections and regions of the country. Now, we had somewhat of a different experience with Europe, which is now converging to be somewhat similar. Let me explain what I mean. If you look at the blue line, the European Union peaked a bit before we did, but when they came down to a baseline, their baseline was well below 10,000. Most recently, as shown on the right-hand part of the slide, as they get their colder weather also in the Northern Hemisphere, they are resurging with cases now of over 65,000 per day. The United States in red peaked predominantly early on, driven by the enormous number of cases and hospitalizations and deaths in the New York City metropolitan area. But when they recovered, other parts of the country kicked in, and our baseline, as shown in the red line, never got down to a low level. When we tried to reopen the country and reopen the economy, particularly in some of the southern states of Florida, Georgia, Texas, Arizona, and Southern California, we had a resurgence of cases up to about 70,000, which then came down. And now, unfortunately, we've plateaued again to about 40 to 50,000 cases a day. And as we're getting into the cooler weather, we're getting more and more cases. So this looks like we're going to have a very difficult fall and winter. But why did we not get down to the baseline that the European Union did? And it relates to the degree of closing that we did, the degree of shutting down of the country. You can determine that by GPSs on phones and measuring the mobility of people over time. As shown here, if you look at the United States in the dark line, we did not shut down vis-a-vis visiting to parks and outdoor spaces as much as Italy and Spain did, which serves as a representation of the European Union as a whole. If you look at workplaces, again, we did not shut down as much as the European Union. And when you got to things like visits to grocery and pharmacy stores, yet again, the lighter lines of Italy and Spain shut down much more completely than we did. Very likely one of a number of factors that led to this discrepancy. Let's quickly talk a little bit about transmission. This is a respiratory-borne virus, and exposure to respiratory droplets, as well as even aerosol, which are droplets that are small enough to hang around in the air for more than just a couple of seconds, and in fact, can infect people particularly in a closed room as air recirculates. The virus less commonly can be transmitted through contact with contaminated surfaces, and it's found in a number of body fluids, as shown on the slide: stool, blood, semen, ocular secretions. But the role in transmission is relatively unknown and likely not a major component of transmission. Animals, both pets and zoo animals, have been shown to be infected rarely. We do not think that this plays a major role in human infection. The risk of transmission varies with the type and duration of exposure, as well as the viral load of the person who's transmitting. Transmissions are seen in household contacts or in places where people congregate together and they don't have masks, referring specifically to cruise ships, nursing homes, and prisons. The factors that increase the risk of transmission include crowded spaces with poor ventilation, and even when people do simple things like speak or breathe heavily or even sing. So you don't need to be coughing or sneezing to transmit the infection. An important component that really distinguishes this infection from so many other viral infections is that about 40 to 45% of people are asymptomatic. And when you do modeling studies, a substantial proportion of the transmissions occur from someone who is without symptoms to an uninfected person. There are some fundamental ways to prevent the acquisition and transmission of SARS coronavirus 2. I have repeated this so many times publicly, but I think it worth repeating now. The universal wearing of masks or cloth face coverings, maintaining physical distance at least 6 feet, avoiding crowds in congregate settings, particularly indoors. Remember that outdoor functions are always safer than indoor functions, and frequent washing of hands is important. Let's take a look at the clinical manifestations. If you look at this slide, you see that very much resembles what we refer to as a flu-like syndrome early on. One difference is the peculiar finding in a certain percentage of individuals of a loss of smell or taste that precedes the onset of respiratory symptoms. Despite the fact that so many people, 40 to 45% without symptoms, when symptoms occur, interestingly, many of them, up to 80%, are mild to moderate enough that they don't require special medical intervention, such as hospitalization. Whereas anywhere from 15 to 20% have either severe or critical manifestations, leading to a variability in case fatality from a few percent to as high as 20 to 25% for people who require mechanical ventilation. Some of these manifestations of severe disease, the most prominent is the acute respiratory distress syndrome. But as we learn more and more about this disease and its manifestations, we see that other organ systems, particularly the heart, with cardiac dysfunction, either as cardiomyopathy or as arrhythmias, sometimes leading to sudden death. Neurological disorders with stroke, in some cases of otherwise normal individuals, a peculiar hypercoagulable state of microthrombi in small vessels, and thromboembolic phenomenon that can lead to stroke, acute kidney injury, and in children, a very curious multisystem inflammatory syndrome, very reminiscent to a disease called Kawasaki disease, in which children following infection, sometimes a couple of weeks later, can get severe inflammatory response leading to hospitalizations and in some cases intensive care. The people who are at increased risk for severe COVID-19 illness are older individuals. And if you look at a parameter such as the rate of hospitalizations per 100,000 population, the difference between young individuals on the left-hand part of the slide and elderly on the right-hand part of the slide is rather profound. In other words, younger individuals clearly do not get as many of the situations or clinical manifestations that make them severely ill. Many are without symptoms at all. This leads to confusion in understanding this disease because it can be relatively benign, if not almost non-existent for some people, and at the same time have a significant death rate among others who have underlying conditions. Speaking of which, people of any age with certain underlying medical conditions are at a high risk for severe COVID illness. These are the medical conditions that are clearly associated with an increased risk. I'll point out just a couple of them, although they all are relevant. Obesity is emerging as an important comorbidity. Diabetes, chronic obstructive pulmonary disease, and a variety of heart conditions. Smoking also looms large here. Those medical conditions that might confer an increased risk, but not as much as the ones on the prior slide, are shown on this slide. I point out a couple that are particularly relevant: hypertension, high blood pressure, diabetes, and overweight, not quite yet obese, but people who are overweight, as well as those with a variety of cardiovascular illnesses. One of the characteristics of this disease that's most disturbing is the extraordinary racial and ethnic disparity. where minorities such as African Americans, Latinx, Native Americans, Alaskan Natives, Pacific Islanders have a higher incidence of getting infected in the first place because of the nature of the jobs they find themselves in, putting themselves right on the front line, out in the community, contacting individuals, putting them at an increased risk of infection. But also, many of them have a higher incidence and prevalence of the underlying comorbidities that lead to a severe outcome. If you look at this striking graph here of, again, the parameter of the rate per 100,000 population of hospitalizations and compare Latinx with African Americans to whites, 368, 375 for the minority group, and 82 for the white non-Hispanics. Also look at the American Indians, the Alaskan Natives, and the Asian Pacific Islanders. Very significant health disparity here. Moving on to therapeutics, the NIH has put together a treatment guidelines panel made up of experts from throughout the country with experience in clinical management of COVID-19 patients. They meet regularly and have put together a living document accessible online at the website shown on this slide. And it's updated in real time regularly with new clinical data based on clinical trials as well as expert opinion. These are some of the therapeutics that are either in play or are being actually tested in clinical trials. Look at the lower half of the slide. I'll get back to the top in a moment. There are direct antivirals, convalescent plasma, which has been now given an emergency use authorization, but we still need to prove or not its efficacy in a clinical trial. Hyperimmune globulin, which is derived from convalescent plasma. Monoclonal antibodies seem particularly promising, as well as immunomodulators to blunt the hyperactive immune response. Take a look at two of these interventions that have been shown in well-designed and implemented randomized placebo-controlled trials. First, remdesivir, which is a direct antiviral, was shown in a randomized placebo-controlled trial in 10 countries, including the United States, shown that when compared to placebo, it significantly diminishes the time to recovery of hospitalized patients with lung involvement. Dexamethasone, a commonly used corticosteroid or steroid that we use for a number of diseases, and a randomized placebo-controlled trial in the United Kingdom of over 6,000 patients, showed that individuals with advanced disease, namely those requiring mechanical ventilation or requiring high flow oxygen, when compared to individuals who don't receive the drug, the dexamethasone group had a significant diminution of the 28-day mortality. This is now widely used with patients with advanced disease. Finally, vaccines. The United States has taken a strategic approach to COVID-19 vaccine R&D. What we've done is support directly or indirectly in the development and implementation of 6 vaccine candidates that I'll show you in a moment are in various stages of clinical trial. The strategic approach is to try and coordinate and harmonize the protocol, to have a common data and safety monitoring board to examine the data, common primary and secondary endpoints, and common immunological parameters to measure the correlates of immunity of the different vaccines. The United States government has invested billions of dollars in this process. These are examples of some of the vaccine platforms and the companies that are involved and where they are in the various phases of trials. There are 3 separate platforms: the nucleic acid, which is utilization of new technologies such as mRNA. There are viral vectors such as adenovirus and VSV, and the standard typical protein subunits. 5 of these 6 that we're supporting are already in phase 3 trial. 2 have actually gone into phase 3 trial on July 27th. And the numbers of people in this trial range from 30,000 to 60,000. And the way things are going now with the trials, we project that by November and December, we will know whether we have safe and effective vaccines. And I think there'll be more than one. One can never guarantee a safe and effective vaccine, but we are cautiously optimistic that we will have one based on preliminary encouraging data in animal models as well as in the phase 1 study. We project that by November and December, we'll have the answer. And then by the end of the year, in the beginning of 2021, we'll be able to distribute doses of vaccines that have been pre-ordered and made prior to even knowing they would work. So a major financial risk was done, but it would save time without compromising safety or compromising scientific integrity. So we would hope that as we get into 2021, we'll be able to begin to distribute vaccines in a priority first to those who are in most need of it, such as healthcare workers and those with underlying conditions. Let me close by showing this last slide, which is the link to the Coronavirus Prevention Network, which would give information about all of the trials that are going on. And if anyone is interested in participating in any of these trials, you can register your interest without any obligation in getting more information about how you might join. So once again, thank you for giving me the opportunity to make this presentation. It's much appreciated.